and welcome to this Ausmed lecture on how to identify heart murmurs. My name is Joanne Reading and I'm a clinical nurse educator at one of Australia's biggest tertiary ICUs. I've spent over a decade gaining experience and expertise managing critically ill patients and have a passion for teaching clinicians to do the same. What we'll look at today are the causes of a murmur classifications, differentiating between valvular stenosis and regurgitation of the heart valves when it comes to murmurs, and how to auscultate for a murmur. When listening for murmurs, we usually auscultate over the areas of the chest that are most closely corresponding with the location of the valve we are assessing. The anatomical locations are the same as when we listen to heart sounds. The first anatomical location to remember is the second intercostal space to the right of the sternum. All the other locations are on the left side of the sternum. So from there, just remember second, third, fourth, and fifth. The second, third, and fourth intercostal spaces are located left of the sternal border, and the fifth intercostal space is located at the mid-clavicular line. Once the locations are in your mind, 2 to the right for your aortic, 2 to the left for the pulmonic, 3 down, which is Erb's point, which is sometimes utilised to give a clearer auscultation of certain murmurs, 4 down, which is your tricuspid valve, and 5 across, mitral valve. There are a couple of simple mnemonics that can be utilised to remember which area corresponds to which heart valve. A popular one is ape to man, so aortic, pulmonic, Erb's point, tricuspid, and mitral. However, I personally like to keep my mnemonics all the same, where I'm not varying between some letterings and some wordings. So I like to remember all people eventually take medication. Aortic, pulmonic, Erb's, tricuspid, mitral. And if you're not using Erb's point, that's fine. Just remove the eventually from it. All people take medication, still works the same. Aortic, pulmonic, tricuspid, mitral. The anatomical locations to remember are the second intercostal spaces to the right and the left of the sternal border, and then just work your way down from there. Second, third, fourth, fifth. The reason the location of the auscultation sites are as described is because each sits directly above and in front of the direction of blood flow that comes out of the valve. Therefore, it will give the clearest sound when assessing murmurs. Now, it's often said if it rarely feels like an awkwardly long time is spent listening to a patient's chest, you are probably not listening for long enough. This lecture will aim to cover the key points to identifying basic murmurs. Auscultating for murmurs and understanding what you're hearing can be difficult and takes a lot of practice. It can take years for a clinician to develop an ear for the various intricacies between different degrees of murmurs. So what are the causes of murmurs? What actually causes a murmur to occur? In its simplest form, murmurs are essentially the wheeze of the heart. It is caused by turbulent flow of blood across the valve, the same way a wheeze is caused by turbulent flow of air through the airway. Murmurs can be caused by blood being forced through a tight area, causing turbulent flow, for example, with valvular stenosis. It can also be caused by blood abnormally travelling backwards through an incompetent valve, causing turbulence when it meets the normal forward-flowing blood flow, for example, with valvular regurgitation. Blood being forced through a congenital anomaly from one chamber to another can also cause turbulent flow, for example, with atrial septal defects or ventricular septal defects, and an increased blood flow through a normal valve, disrupting normal laminar flow, can also cause turbulence. So, for example, high output states such as sepsis or in pregnancy. There are various definitions when we look at understanding murmurs, and the first one that we're going to focus on, and probably the key one we're going to focus on, is timing. This is the portion of the cardiac cycle the murmur is heard. When clinicians are first learning to auscultate murmurs, focusing on whether they can hear the murmur during systole, diastole, or continuously is the key objective. While this lecture will highlight some of the other definitions and classifications associated with murmurs, the main focus will be on identifying which part of the cardiac cycle a murmur is heard and relating this back to which valve is potentially affected. Systolic murmurs are associated with semi-lunar valvular stenosis. So these are the aortic and pulmonic valves. AV valvular regurgitation, so these are the tricuspid and mitral valves, atrial or ventricular septal wall defects, or HOCM, hypertrophic obstructive cardiomyopathy. Diastolic murmurs are associated with semilunar valvular regurgitation and AV valvular stenosis, so the opposite problem to what systolic murmurs are associated with when we're talking about valvular dysfunction. Continuous murmurs are associated with combination murmurs, so a systolic and a diastolic murmur present concurrently, or a patent ductus arteriosus, PDA. For the remainder of this lecture, we will focus on valvular regurgitation or stenosis being the pathophysiology that results in the murmur. So let's talk a little bit about systolic versus diastolic murmurs. If a murmur is present, there will be a whooshing sound that will be heard at some point through the cardiac cycle. This whoosh can sound very different, and I'll give you a link at the end that will talk through, that will link you to various sounds and how that might actually sound like when we're looking at different types of murmurs. When listening for murmurs, being able to identify S1 and S2 heart sounds is paramount. This is the lub-dub that we hear when auscultating heart sounds, with the lub being S1, indicating systole has begun, and the dub being S2, indicating that diastole has begun. The key to differentiating between systolic and diastolic murmurs is recognizing whether the murmur occurs between S1 and S2, or if it occurs after the S2 heart sound. A systolic murmur occurs during systole, it's in the name. Therefore, it will occur between the S1 and S2 heart sounds. Remember, S1 indicates a systole has begun, so if you're going to have a systolic murmur, it's got to occur when S1 begins, and it has to finish before S2 comes through. The whooshing sound often overpowers the heart sounds, making heart sounds a little bit harder to hear when there is a systolic murmur present. When valvular dysfunction results in a systolic murmur, we understand this is caused by semilunar valvular stenosis and or AV valvular regurgitation. An understanding of the anatomy and physiology of the cardiac cycle will help you understand why this is the case. During systole, the semilunar valves are opened and the AV valves are closed. So essentially, we know that the tricuspid valve and the mitral valves are shut and your aortic and pulmonic valves are opened. Normal flow occurs forward through these semilunar valves. Therefore, if these valves are stenosed, there will be more turbulent flow resulting in the murmur. Regurgitation of these semilunar valves during systole doesn't actually matter. It can't be identified as a systolic murmur because the function of the valve at this time is to allow blood to move forward rather than stopping the backflow, as compared to its function during diastole. However, the function of the AV valves during systole is to prevent backflow from the ventricles into the atria. Therefore, if regurgitation of these valves were present during systole, the backward movement of blood will cause turbulent flow resulting in a murmur. Once again, stenosis of the AV valves during systole doesn't actually matter. You can't identify it during systole because the function of the valves at this time is to stop blood moving backwards rather than allowing it to move forward, as compared to its function during diastole. So when we think about systolic murmurs, we've just talked about how we know that it's our mitral and tricuspid regurgitation that causes a problem, and it's aortic and pulmonic stenosis that causes a problem. So an easy mnemonic to remember which valves and their associated issues are causing the problem is the mnemonic known as Mr. Taps. When you look at the first three letters of Mr. Taps and you split them from the last three letters, you get MRT, and you get APS. The MRT can be split apart. So you can go MR and you can take TR from that. So essentially tricuspid regurgitation and mitral regurgitation. While the APS, you can get AS from that and PS from that. So aortic stenosis and pulmonic stenosis. So whenever we think about systolic murmurs, there are 4 conditions that will cause a systolic murmur when we talk about valvular dysfunction. That is tricuspid regurgitation and mitral regurgitation and aortic stenosis and pulmonic stenosis. So just remember, if you hear a systolic murmur, think Mr. Taps. A diastolic murmur occurs during diastole. Therefore, it will occur after the S2 heart sound. Diastolic murmurs sound distinctly different to systolic murmurs because the S1 heart sound can be clearly heard, followed by a whooshing sound that often overpowers the S2 heart sound. When valvular dysfunction results in a diastolic murmur, we understand that this is caused by the semilunar valvular regurgitation, or AV valvular stenosis. The opposite concept around the cardiac cycle of systolic murmurs apply for understanding why this is the case with diastolic murmurs. So during diastole, the semilunar valves are closed and the AV valves are the ones that are open. Normal flow occurs forward through the AV valves from the atria into the ventricles, and therefore if these valves are stenosed, there will be more turbulent flow resulting in a murmur during diastole. Regurgitation of these valves during diastole doesn't matter because as the function of the valve is to allow blood to move forward rather than stopping backflow, it's very different to its systolic function. However, the function of the semilunar valves, so our aortic valve and our pulmonic valve, during diastole is to prevent backflow from the pulmonary and systemic circulation back into the ventricles. Therefore, if regurgitation was present, this backward movement of blood will cause turbulent flow, thereby resulting in a murmur. Stenosis of these valves during diastole doesn't matter because the function of these valves at this time is to stop blood moving backwards rather than allowing it to move forward, which once again, compared to its systolic function, is the opposite. As diastolic murmurs are caused by the exact opposite valvular pathophysiology compared to systolic murmurs, just think the opposite of Mr. Taps if you hear a diastolic murmur. So remember, systolic murmur, you're thinking Mr. Taps. Diastolic murmur, you're thinking the opposite of Mr. Taps. So if Mr. Taps is MR and TR, we're now thinking the opposite, MS and TS. And instead of the APS components, so AS and PS of Mr. Taps, we are thinking the opposite, AR and PR. Therefore, mitral and tricuspid stenosis or aortic and pulmonic regurgitation are the causes of diastolic murmurs when we talk about valvular heart disease. So let's compare the two. With a systolic murmur, the murmur occurs at or after S1 and finishes before or with S2. This image helps you visualize this. What does that actually sound like? So it can sound something like this. Shh, 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 shh. With a diastolic murmur, the murmur occurs at or after S2 and finishes before or with S1. This image will help you visualize this. How does this sound different to a systolic murmur? It can sound something like this. Shh, 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 compared to shh, 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 shh. And what are the potential causes of a diastolic murmur? So we think the opposite of Mr. Taps. An additional tip that I can offer when auscultating murmurs is to keep one hand feeling for the pulse of the patient. If you can feel the pulse followed by the whoosh, it's a systolic murmur. If you can hear the whoosh and then feel the pulse, it's a diastolic murmur. This is especially useful if the patient has a faster heart rate, which tends to blend together the heart sounds and the murmur. So let's go through a step-by-step process to interpreting murmurs. The 4-step process that can be utilised to determine what is the most likely valvular issue associated with the murmur is this. Step 1. Is the murmur systolic or diastolic? So if it's occurring between S1 and S2, it's systolic. If it's occurring after S2, it's diastolic. Once you've worked out if the murmur is systolic or diastolic, you need to try to figure out which valvular dysfunction is associated with this type of murmur. So if it's systolic, we think Mr. Taps. So it could be mitral regurgitation or tricuspid regurgitation, or it could be aortic stenosis or pulmonic stenosis. If it's diastolic, we think the opposite of Mr. Taps. So we think it could be mitral stenosis or tricuspid stenosis or aortic regurgitation or pulmonic regurgitation. Once you have determined if the murmur is systolic or diastolic, you are left with 4 potential valvular issues. This helps us move on to step 3. We try to further narrow down these 4 valvular dysfunction options simply by asking the question, does the murmur get louder during inspiration? If yes, it is likely a right-sided heart valve, so either the tricuspid or pulmonic valve. If the answer is no, so it sounds the same the whole way through, respiration doesn't really increase or decrease the sound, it is likely a left-sided heart valve that's involved, so either the mitral or aortic valve. The reason for the increased sound during inspiration on the right-sided heart valves is due to an increased venous return to the right side of the heart during inspiration, which increases blood flow across the right-sided heart valves, thereby increasing the intensity of the murmur. So now with only 2 remaining potential causes of the murmur left, Step 4 focuses on assessing where the murmur sounds the loudest out of the 2 valve areas that are remaining to assess. So remember, we had our aortic, we had our pulmonic, we had our tricuspid, and we had our mitral. So we're going to listen to whichever 2 murmurs we think it could still be, and depending on which side sounds the loudest, this is likely going to be the valve that's involved and the associated issue that's causing the murmur. So whether it's regurgitation or stenosis of the aortic, pulmonic, tricuspid, or mitral valve. And remember, it takes practice to distinguish between systolic and diastolic murmurs and identify a potential valvular cause, purely because it isn't something that we are listening to every single day. Even if you did auscultate chest every single day, not every patient has a murmur. So we need to listen to 100 normals before we can start to really identify abnormal, and then we need to listen to even more abnormals to be able to distinguish the differences between each type of abnormal. So it's highly suggested that if you know the patient has a past history of valvular regurgitation or stenosis, take that active attempt to actually go in and auscultate their heart sounds, because it's probably a good opportunity to hear a potential murmur that you know you are looking out for, rather than listening to a heart that you're not sure whether that's going to be a normal heart sound or whether there's going to be a murmur present. Now, let's have a little bit of a talk about advanced murmur assessments. Once you become more comfortable with the basics of murmur auscultation, there are more advanced assessments that can provide the clinician with even further diagnostic value. I know cardiologists who can identify whether the stenosis or the regurgitation that they're listening to is mild, moderate, or severe, just based on auscultating the heart sounds and murmur. This, of course, takes practice. For me, I'm pretty happy being able to identify the basics and allow the echocardiogram to determine the rest of the information for me. So to finish this lecture, I'll provide you with an overview of some of these assessments. To start with, let's talk about intensity. That's how audible the murmur is. primarily determined by the volume or velocity of blood flowing through a valve, how turbulent the blood flow is, and the distance between the stethoscope and the valve. You may also hear the terminology of pitch. Pitch is the frequency of the murmur that is classified as low, medium, or high. The bell of a stethoscope can identify low-pitched sounds, so the little part of the stethoscope, while the diaphragm, the larger part of the stethoscope, can identify medium to high-pitched sounds. Radiation is another type of assessment that can be utilised that gives us some diagnostic value. This is essentially the direction the sound of the murmur travels, usually in the direction of blood flow. An easy way to remember the direction of radiation is that systolic murmurs, so starts with an S, radiate to the sky. So you're listening to a murmur and you'll hear it sound louder as it moves upwards. Versus diastolic murmurs, so starting with a D, that radiate down, starting with a D. Okay, so you will listen and it will sound louder as it starts to move down through the blood flow. One of the key things that people often refer to as well when they start to understand the intricate details of how a murmur sounds, they start to talk about the quality of a murmur. And this is essentially the shape of the sound if it was visualized. So we talk about crescendo, where it's an increasing intensity. We talk about decrescendo, which is a decreasing intensity. We talk about a diamond-shaped pattern, or that crescendo-decrescendo look, which is increasing and then immediately decreasing within the same murmur. And we talk about rectangularly shaped murmurs, which is a constant intensity through the entire murmur. Murmurs can be further graded based on how audible they are. There are 6 different grades of audibility. Grade 1, the murmur is faint and not easily heard, and these murmurs are often missed. Grade 2, the murmur is faint but immediately audible when placing the stethoscope on the patient's chest. Grade 3, a loud murmur is readily audible, but there's no thrill. So a thrill is essentially when the murmur causes enough turbulent flow that the clinician can feel a vibration by placing their palm on the patient's chest. Grade 4 is a loud murmur with a thrill. So grade 4 and higher murmurs will always possess a thrill. Grade 5, the murmur is audible with only the rim of the stethoscope touching the patient's chest. So it's pretty loud at this point. And grade 6, the murmur is audible with the stethoscope not touching the patient's chest. So very loud. We sometimes say that the patient's neighbour can hear that patient's murmur. So as I said, a lot of practice with murmurs is important. And if you would like to practice hearing various types of heart murmurs as well as heart sounds, the following link is a great resource for further information and practice. Thank you for watching this lecture on how to identify heart murmurs. I hope that you have gained some valuable insight into the complexity of auscultating murmurs, as well as picked up a few handy and clinically applicable tips for basic murmur identification. If you would like further information about the other clinical implications of valvular dysfunction, there are further series lectures that talk about valvular heart disease for your perusal.